mode.
Good morning, good afternoon, or good evening, depending on where you're joining us from. We're very happy to have you be with us today for the webinar of Atypical Parkinsonian Disorders, an overview and discussion of application to LSVT LOUD and LSVT BIG. My name is Angela Halpern, and I will be moderating and presenting on today's session. And also presenting with me today is my colleague, Heather Ciance. And as we go through today's presentation, we would like to acknowledge our funding support, which has helped to make LSVT BIG and LSVT LOUD possible and what it is today. So we've been lucky to have funding support from the National Institutes of Health, and you see some grant numbers listed here, as well as the Michael J. Fox Foundation, the Parkinson Alliance, and the Davis Phinney Foundation. I did introduce myself. My name is Angela Halpern. I'll get into our bios a little bit more. And my colleague, Heather Ciance. Heather is a physical therapist, and I'll show you her bio in just a little bit. And I am a speech-language pathologist. Here is a little bit more information on our instructor biographies. So I am a speech-language pathologist, and I work in Denver, Colorado. I've been a part of Dr. Ramig's research team since 2000, and so I've been an instrumental part of a lot of the research that was done on LSVT LOUD. I also now am the Chief Clinical Officer for LSVT Global and an LSVT LOUD faculty member. Heather Ciance is a founding therapist of the Dan Aaron Parkinson's Rehab Center at Pennsylvania Hospital, and she received her bachelor's degree from the University of Scranton in Pennsylvania and her master's degree from St. Joseph's University in Philadelphia. Heather has a vast amount of experience working with individuals with Parkinson's disease and also individuals with atypical Parkinsonian disorders. So we're very happy to be with you here today. We do want to disclose that all of the LSVT faculty have both financial and non-financial relationships with LSVT Global. Non-financial relationships include a preference for LSVT BIG and LSVT LOUD as a treatment technique, and financial relationships include that we do receive consulting fees, lecture honorarium, and travel reimbursement. And as I mentioned earlier, I'm a Chief Clinical Officer for LSVT Global, so I am an employee of LSVT Global. Today for our presentation with this webinar, we are going to walk through and explain some advances in neuroscience and the impact that this has on the field of rehabilitation. We're going to get in and describe some atypical Parkinsonian characteristics. We're going to describe how clinical factors affect speech of individuals with atypical Parkinsonism and provide some examples of adaptations used for LSVT LOUD and LSVT BIG in these populations. And then finally, we're going to go over and review some ways in which treatment strategies can be tailored to meet the needs of people with atypical Parkinsonism. I'm now going to turn the presentation over to my colleague Heather to talk to you about some of the advances in neuroscience and the characteristics in atypical Parkinsonism.
Thank you so much, Angela. I appreciate that introduction. And I'd like to thank everyone for taking the time out of their busy days to join us to learn about a really wonderful way in which rehab of both the voice and the body can be applicable to individuals living with the atypical Parkinsonisms. We like to begin with saying that it truly is a stunning time to be involved in neurological rehabilitation. We have long known that we have wonderful effects on the voices and body movements of individuals with Parkinson's, and we're really learning now about how we can further help those people with the atypicals. We know that we have science and research that really help to support what we are doing, but we also have that support from knowing the medications that are helpful and the surgeries that are helpful, and those are typically for individuals with Parkinson's. Unfortunately, in our population of people with the atypical Parkinsonisms, it truly only is the therapies that are helpful for this. So that's why it's so exciting for us to be talking to you about this today. We have research that has helped us to identify what we call the key principles of exercise that help us drive activity-dependent neuroplasticity. And that's a fancy word and a way of saying brain change. So we know how we can actually make the brain work better for us by actually driving it in a certain way with certain types of exercise. And we really have shown through the literature that exercise for the voice and for the body really can improve brain functioning, make that brain change, and may actually begin to slow the progression of these diseases. We know that exercise is medication and that it really can be the best thing for us. Next slide. So we know that we have these 3 legitimate therapeutic options. As I said before, unfortunately, in the world of atypical Parkinsonisms, we know that the deep brain stimulation surgery is not a possibility as it is for individuals with idiopathic or regular quote-unquote Parkinson's disease. And we know that pharmacological agents, medications, really only have limited help in these individuals. So what we're really relying on for people with atypical Parkinsonisms is our voice and body exercises. So even though we have those for Parkinson's, we know more so for you with the atypicals, having physical, occupational, speech-language pathology is going to be our best route to help you. Next slide. What are we talking about when we say the term atypical? What is considered an actual atypical Parkinsonism? Let's move through some of the next slides and we'll talk a little bit about the ones that we will speak about today. So an atypical Parkinsonism, really that term is sort of what we call an umbrella term. It covers a variety of different neurological disorders. And some of these disorders can really look like Parkinson's disease in the beginning. And you yourself or your loved one may have been originally diagnosed with Parkinson's, and through time and over the years of working with your neurologist, those little things that just didn't seem right may have led them to think that it wasn't just Parkinson's, that it was more of something atypical. And what is happening there is that there is cell degeneration and that there is different proteins in the brain that are attacking those good cells that we need, and they really are making the connection in the brain, it's not working anymore. It's really not controlling well the areas that control speech, that control voice, and control body movement. Now, the causes of their symptoms, like I said before, it's different from classic Parkinson's disease because it does attack different parts of the brain. In the beginning, it can look very similar. You can see with some people having tremors, a lot of slowness of movement, a stiffness or a rigidity, and then also having problems with gait and posture. Now, also, these symptoms sometimes of different things that we see in the atypicals aren't typically present in Parkinson's so early on and may be much more prevalent and prominent. So people with excessive falls very early on in the course of their disease where they fall backwards, or people who are having really dramatic problems with blood pressure and feeling as though they're going to pass out, or people who are having much more difficulty with their eye gaze, or really rapid progression of speech difficulties and swallowing difficulties. That's not typical for Parkinson's, and that's where that term goes into that it's an atypical or a Parkinsonism syndrome. Next slide. So again, the causes of this, no specific cause has been truly identified. Usually it's a non-hereditary. It's thought to be very sporadic. It's considered an orphan disease. It's considered something that is very, very rare. And the way that we classify these atypical Parkinsonisms are by the patterns of damage. So where the injury or insult to the brain sort of starts, and then how it changes throughout and what it causes you to have difficulty with early on. Again, whether that's visual differences, if that's balance problems, if that is swallowing problems, and we kind of follow them through their natural course. So again, with these people, like I said, with the dopamine, we're not able to use the levodopa, carbidopa, the Cinemet, to really help patients with this because of the loss of the dopamine receptor. So people typically, maybe early on, may respond slightly to these medications, but overall don't, because the actual cause of the disease and the areas of the brain affected are different between the atypicals and idiopathic Parkinson's. Next slide. So how are idiopathic Parkinson's and the atypical Parkinsonisms different? So what is most important is really getting an accurate diagnosis. So use of really precise diagnosis criteria. So our doctors, our movement disorder neurologists really look at what you are describing. What are the difficulties that you are having? Are you presenting with certain things that are very typical of that disease process? And again, in someone who may not be very used to seeing people with these different disorders, it may be more challenging to receive that correct diagnosis. But we know that getting that correct diagnosis is ultimately very important so that we know what the course of treatment will be. Now, those treatments are really going to vary depending on what the condition is, and we're really going to, at least as therapists, work to treat whatever that deficit is that you are having. The difficulty, again, with the atypicals is, unfortunately, they tend to progress more rapidly, so speech and swallowing problems, cognitive issues, and falls can actually start much earlier. And again, we're less likely to see a response to medications. Now, again, additional features of the diseases may respond to different medications, so there may be other issues, and I had said earlier about blood pressure dropping. So that's something called orthostatic hypotension, and we do have medications that can help with that. So some of those symptoms, while we don't use specific medications directed at Parkinson's, there are other classifications of medications that can help with different symptoms. Right now, the current treatment and what we're really thinking about as the best course of treatment is focused on a multidisciplinary focus on those symptoms. So it's going to be a combination of your care team, your family members. It's going to be a social worker, a physical therapist, an occupational therapist, your speech language pathologist, and your neurologist, all working together to really focus on how can we attack each of those symptoms that you're having, and how can we help you to stay as safe and as functional and as able to eat and communicate as well as possible for as long as possible. Next slide. So we're going to talk about progressive supranuclear palsy first, because this is the most common form of atypical Parkinsonisms. And oftentimes people will have this sort of worried or angry facial look, or they look as though sort of a deer caught in the headlight. And that comes from a rigidity of the facial muscles, as well as difficulty with the movement of the eyes and difficulty with blinking. So we find in this population that eventually people with PSP do lose the ability to track their eyes and look up and down. And you can think about how challenging it would be to prevent falls when you can't look down to see what might be on the floor. So this leads to those fall problems, as well as I mentioned before, the early postural instability, or that loss of balance backwards. And because in progressive supranuclear palsy, the front part of your brain, or your frontal lobe, is affected, that's the part of your brain that controls your emotions, your personality, kind of your ways of planning, your ways of being appropriate in social situations. This can affect that part of the brain and lead to difficulties in those areas, as well as cognition. Next slide. Now, multiple system atrophy is the next atypical we'll talk about, and that is the second most common form. It previously was referred to as Shy-Drager syndrome, or olivopontocerebellar atrophy. Now, MSA can come sort of in three varieties, depending on the difference in the symptoms that somebody has. So there is MSAP, where someone begins sort of looking like someone with Parkinson's disease. And then there is MSAC, where people have a lot of cerebellar problems or areas of the brain that really kind of control that balance. So they have a lot of ataxia, a lot of incoordination of movements and falls. And then we also have MSAA, where you have what we call autonomic problems. And that is features controlled by the autonomic nervous system, so where you have those episodes of orthostatic hypotension with changes in blood pressure dropping quickly when you change. There is early disturbance of sexual, bladder, and bowel dysfunction, discoloration of the skin, and a lot of difficulty with acting out of dreams and sleep apnea. So sleep disturbances can run very, very high in the population of people with MSA. Next slide. So I talked a little bit about how we divide the different variants up, but some of the other typical features that we'll see with MSA is something called anterior callus, and that means where the head has a head drop and the head falls forward. It could also even manifest itself into a full frontal tilt of the whole body in the trunk. And it can also not just go to the front, but also to the side, and we call that the Pisa sign, and you can think about the Leaning Tower of Pisa. I mentioned earlier the loss of coordination, so difficulty with reaching out for things and feeling where things are and getting them to where they need to be, or placing your foot down. And again, this rapidly progressive course of the way this disease process moves. Next slide, please. So we're going to show you a video example of a patient of mine who I'd worked with who had multisystem atrophy, and we asked her to talk to us about some of the changes in her voice and swallowing. So let's take a look at that video. So I'm not sure if you're able to hear that video playing here. You may just be kind of seeing her movements, but what was happening in this video was she was talking about how she really had to think about each thing she was saying, that she couldn't just rapidly speak what she was saying, and she really had to think about moving her mouth and voice to get everything to go where it was. And she said, you know, you may think that this sounds good, but to me it's completely different than what I am normally used to. Next slide. And then we have something known as vascular Parkinsonism, and this is where people, again, present sort of like they look like they have Parkinson's disease, but their symptoms tend to be more in the lower part of the body, into the legs. And this is caused not by the same causes that cause Parkinson's, but this is caused by multiple minute or very small strokes in the brain where there's a loss of blood flow to particular areas in the brain. And patients with this tend to have difficulty, again, with balance, with walking, and are at a much higher risk for falls. Next slide. And then we have Lewy body dementia. Now, Lewy body dementia, this is a kind of an early onset of dementia where it comes quickly with symptoms of Parkinson's. So people can, again, begin looking like they have Parkinson's, but they quickly move into a type of dementia. Now, this can sometimes come along with it, or it can precede the Parkinson's kind of symptoms, but they typically go hand in hand. The thing that's much different about those with the Lewy body dementia is they suffer from what we call visual hallucinations, and that's where we're seeing animals or objects or people that aren't really there. And the third thing that's different about this type of dementia is that these symptoms can fluctuate, meaning that someone could be really clear and understanding what's going on one day, and then the next day be very confused as to what's going on. So it's a very fluctuating kind of disease process with Lewy body dementia. Next slide. We're talking about CBD, or corticobasal degeneration. With CBD, the main kind of differentiation from the other atypicals is that individuals begin to get what we call apraxia, and this starts with kind of difficulties on one side of the body more than the other. That's what we mean when we say asymmetric, where people can't figure out, okay, this is, I pick up a key and this is how I'm supposed to turn the key. They're not quite sure how to use devices in the environment. And then we see things like dystonia, where we have abnormal kind of contractures or posturing or twisting of the arms and legs that moves into something called alien limb, where the individual's hand or leg almost seem to have a mind of their own, where the person isn't choosing to make a certain movement happen, but it's just happening on its own. So it has that kind of alien kind of feeling to it. And again, unfortunately, this disease also is not very well treated with the common anti-Parkinsonian medications. Next slide. So I'm now going to turn this over to Angela, and she's going to talk to you about how we use LSVT LOUD for the atypical Parkinsonisms.
Thank you, Heather, for that wonderful overview and all that great information. I'm going to try to replay this video before we get into the LSVT LOUD to see if we can get the sound to come across better this time, because I think it's a wonderful video example.
Again, I used to be a fast talker, but now this is as fast as I can go. So I hope you understand me. I have a little trouble getting the words out. That sounded pretty good for me.
So hopefully you were able, that audio came through that time for you. And one other thing I wanted to bring up before we get into talking about LSVT LOUD exercises is how you can ask questions. We will have a time for questions at the end of this webinar. And if you would like to ask a question and you're thinking of it now and you want to go ahead and type it in, you can type a question in the question box on your control panel. Then at the end, when we get to the question section, I'll read your question aloud and either Heather or myself will respond to the question. You can also raise your hand, and you can raise your hand by clicking on the hand icon on your control panel. I'll then see that you have a question. I'll unmute your microphone and call out your first and last name, let you know that we've unmuted your microphone, and then you can ask your question aloud to the group. And then as always, you can always email us with questions as well. We're going to talk now about voice and speech treatment, LSVT LOUD, as an option for voice and speech treatment in atypical Parkinsonism. LSVT LOUD has over 25 years of funding from the National Institutes of Health and has been proven via research to be an efficacious voice and speech treatment for individuals with typical idiopathic Parkinson's disease. So the majority of the research has been done with people with typical Parkinson's disease, but we do have some case studies, and I'll show you some slides with that information in a bit, that's published in the literature of application of LSVT LOUD to atypical PD. So as we discuss applying LSVT LOUD to atypical Parkinsonism, it's important to keep in mind that LSVT is LSVT is LSVT. So whether we're utilizing this with someone who has a typical Parkinson, atypical Parkinson, or even no Parkinson's at all, we don't change the protocol. It's 4 times a week for 4 weeks, 16 one-hour sessions, and we complete each of the components that we're going to talk about here briefly in each treatment session. So if you're not familiar with LSVT LOUD, the first half of the session are the daily tasks. These always take the first 30 minutes of the session. So with these 3 daily exercises, we're doing sustained ah, and we're looking for increasing loudness of the voice to a normal loudness level, and this is a core strengthening exercise for the voice. And then we're also pushing duration of how long people can hold out that ah to try to work on respiratory support. We do a minimum of 15 repetitions of that ah. Then in Parkinson's, we also see that people's speech can sometimes become monotone, so there's not as much inflection. So we do pitch stretches of ah or ah, And we do a minimum of 15 of each of those, working with each individual person to push them to higher effort levels to really get that nice stretch in the voice to translate into better inflection. And then the third thing that we do in every session are what we call our functional phrases. So we have individuals come up with 10 things that they say every single day. And then we repeat those 10 things 5 times during each session. The point of this is always working in LSVT loud to get individuals to a normal loudness level. We're not getting people to a shout, it's just to normal loudness. So when we've practiced those phrases over and over in treatment at a normal loudness level, they become so overlearned that if someone goes home and says, "What's for dinner?" in their normal loudness voice, it reminds them to use those techniques we've worked on treatment to increase the voice from a quiet voice to a normal loudness voice. The second half of every session is what we call the speech hierarchy. Here we take what we've trained, increasing amplitude of voice to normal loudness, into a variety of speaking and reading activities. So we start simple and gradually get more complex so people can be successful at each stage. So week 1, we're reading at word phrases. Week 2, it's sentences. Week 3 is all reading, and week 4 is conversation. And we're throwing in at the word phrase, sentence, paragraph reading level conversation activities that start simple and gradually get more complex as well, always with the target goal of increasing the voice to a normal loudness level. When we think about applying LSVT loud to individuals with atypical PD, some things that we might see clinically are greater variability across individuals in the treatment effect. Also, maybe greater variability from person to person. As Heather introduced previously, for some of the atypical Parkinsonisms, there can be a lot of variability in function from day to day. And so as a speech therapist, what I like to do is have a variety of activities available. So if someone's having a more difficult day, we have things so that that person on that day can feel successful as well. We do see, and this is shown in the research that I'll show you in a later slide, that individuals with atypical PD can show improvement using the LSVT loud protocol. For some individuals, those gains may not be as significant as what's reported in the literature for typical idiopathic Parkinson's disease, but gains can be made. And we also see that sometimes it may be a little more difficult for individuals with an atypical Parkinsonism to maintain those treatment effects. And so it's really important as a speech therapist working with someone who maybe has an atypical PD to have that person come in more frequently for more frequent follow-ups. So coming in maybe every couple of months for a tune-up session to get someone recalibrated to the amount of effort and loudness required to have a normal loudness voice. We also find that we may put more emphasis on calibration effort and activities, and by calibration we mean helping people to see that this voice and speech that may feel too loud to them is really at a normal loudness level. And calibration activities include things like playing back the individual's voice to help them see that the voice really isn't too loud, and doing a lot of that in the treatment session, and showing them that the voice that feels normal is really too quiet. Also doing things like emphasizing activities outside of the treatment room with family and care partners. So using this new normal loudness voice outside of the treatment room and getting exercise and practice with that in a variety of communication activities, and to see that everyone in the environment is also saying, that voice sounds great, I can hear and understand you, no you're not shouting, no it's too loud, it's really a great normal loudness voice. So as a speech therapist, the first thing that I do when someone comes in is I'm going to do some stimulability testing, because I want to see if someone is going to participate in LSVT loud treatment, if it's appropriate. So does increasing loudness of the voice have an impact? Does the voice get to a normal loudness level if it was quiet before? Does the quality of the voice improve? Is there an improvement in articulation? And so through the stimulability testing, I do a variety of speech activities and look at the impact of loud. If I see that loud has an impact, then the next step would be to try 4 consecutive sessions of doing LSVT loud, so that 1 hour of treatment, doing those activities I introduced earlier, and documenting the impact and quantifying the changes that I might see. Then at the end of that week, I could sit down with my patients, with the family members, and we can all look at the progress that has happened within that week and decide, do we think this treatment is appropriate? Is it having an impact? If yes, then we continue on with weeks 2, 3, and 4 of the treatment. A few pearls of wisdom when we're thinking about LSVT loud with atypical PD. As a therapist, I find that I may need to spend more time what we call shaping the voice. So with LSVT loud, it's called LSVT loud, but keeping in mind, like I said earlier, we're only getting individuals to a normal loudness voice. We're never training a voice that is strained, that is pushed, that is a shout. It's only called LSVT loud because to the individual we're working with, the voice feels loud. It's really a normal loudness level, but because of the sensory mismatch in Parkinson's, it feels too loud. So a very important part of what I do as a speech therapist is shaping that voice so it's normal loudness with good quality. If you're participating in LSVT loud treatment, you should never feel any strain. You should never feel a sore throat. That's not a part of the treatment. Your therapist will work with you so you can get to normal loudness with a good quality, and they have lots of tools and techniques to help with that. We may see that voice quality may not get to be this shockingly improved voice. There may still be a little hoarseness or harshness with the voice, but the therapist will make sure that you're producing the voice in a healthy way. Also, I see sometimes individuals with atypical PD may not be able to hold out the as long, but that's okay. We can still increase the effort and work on that, and we may just do more repetitions of that And for anyone I work with, whether they have an atypical PD, typical PD, I'm always going to make sure and go through an assessment of any other medical issues that are going on. And if you're working with a speech therapist, they should be doing this with you as well. So if there are any other cardiac or respiratory medical concerns, then getting clearance from the doctor is what the speech therapist would do before embarking on LSVT loud, just to make sure you're safe to participate in the treatment. People think, well, it's voice exercise. It's, why do I need a clearance? But it is exercise, and my patients will tell me after we've been working, whew, I feel like I've had a good workout, because we're working the whole motor system, the breathing, the voice, increasing that effort. When I'm doing reading and conversation, some things that I might see is sometimes the loudness is easier for people to achieve in speech than it is in that sustained phonation. Also, we may need to make some adjustments in the reading material. So if someone has PSP and they have an issue with vertical gaze, may need to hold a piece of paper and move it for the person so that they can just focus on keeping their voice loud and don't have to worry about where to look on that paper with the vertical gaze. So as a therapist, I would be manipulating that. Or if someone has postural issues that makes it difficult for them to see, I would be manipulating the reading materials in the environment so there's the ultimate success. If someone has difficulties with reading because of the linguistic complexity of the reading material, as a therapist, we want to develop reading material that is easy for someone to read, because the goal is to practice the loud voice and get the exercise with that, not to work on language. So I don't want individuals that I work with to feel frustrated by the material they're reading. Rather, I want them to be able to have that success of getting their voice loud. Also, as a part of LSVT Loud, we're always selecting materials for reading and conversation that are personal and salient. And that's very important when we think of principles of neuroplasticity, because saliency of tapping into things that are important to the individual is essential for generalization and carryover of this new voice outside of the treatment room. So I find out what my patients are interested in, and those are the types of things we read and talk about. If someone is really having difficulty with reading, we might do things with repetition of words and phrases or picture and photo description instead. The goal being that I want to keep that motor practice going for individuals throughout the treatment session. If someone is having a lot of difficulties and maybe they're more severe and in the disease process, our goal is always to go into treatment with the goal of conversational speech. And we don't underestimate that expectation for anyone. So we go in with the idea that we're going to achieve conversational speech in 16 sessions. However, once we dig into treatment and we've pushed our clients to their maximum ability, it might become evident that in order to be able to stay loud, we might need to focus on more of a core set of things that someone can say every day so that they have the means to communicate. We want people to be successful, not feel frustrated. So by having a core set of phrases that are overlearned, that can be heard and understood, this can still have a positive impact because individuals have important things to say and we want them to be able to share this information and be heard and understood. I'm going to show you a video now, and this is someone who does not have an atypical Parkinsonism. They actually have idiopathic Parkinsonism, but they had a more atypical speech pattern. And so this speech pattern is called palileia and can sometimes happen with Parkinson's disease. And it's a festination of speech. And you'll see what I mean when I show the video as far as these rushes of speech. So with this individual, we tried LSVT LOUD, and the loudness was able to improve, but the rushes of speech were still there. So then we tried to add an alphabet board, and you can see the difference post with the use of the alphabet board.
The happiest days of my life is when I get shy cough, maybe. And this is thing I play that's from something that is allowed me. And that's a mother and I'm approaching the ship and I just look like down. So I'm so happy.
Tell me a little bit about your experience here. This is session 15. We have one more session tomorrow.
Yes.
Tell me what you've learned from the therapy that you've done.
Something I have done and talk slowly.
Uh-huh.
Use this board.
Okay. I want you to say that again using the board.
I learned to use this board to slow myself down.
Good. Okay. How about today, after you leave here?
Shopping.
Shopping. Tell me where you're going and what you're going to buy.
Food.
Give me a whole sentence without the board. I know it may not come out well, but it's for the camera.
Food shopping.
Okay. Now with the board.
We are going food shopping.
Okay, so that's a sample of the use of an additional technique of this alphabet board, and you could see it had a dramatic effect for this individual. Based on your download speed for your personal internet, for some individuals these videos may come across a bit jerky or delayed, but I think you can still hear and see those differences of how that alphabet board was helpful for this individual. So we've talked about the motor speech system and the exercises that we do to improve that, but with the intensive exercise, there's also this issue that I touched on briefly of calibration. So in Parkinson's disease, we see a mismatch between the online perception of output and how it's perceived by others. So my patients will say to me when they come in with a quiet voice, I'm not too soft, and when I get them to a normal loudness voice, they'll say, I can't speak like this, I feel like I'm shouting. And that's because of the impact of Parkinson's disease on the sensory system, creating the sensory mismatch. So we do a lot of activities in the treatment session to directly address this, playing back the voice so people can see it's really not too loud, and doing carryover activities outside of the treatment room so you can get feedback from other people that the voice just sounds like good, normal loudness. And I tell my patients, if you don't feel like you're talking too loud, you're not talking loud enough. These are some of the studies, and if you're interested in getting the direct references, please email us and we can be happy to send those to you. But these are a couple of the small group and case studies that were conducted looking at the evidence for LSVT LOUD for atypical PD. And in a nutshell, what was shown in these studies was that the people with atypical PD could make some improvements in sound pressure level following the LSVT LOUD treatment, so showing evidence to support this as a treatment method. And final suggestions before I turn this back over to Heather. Early intervention is essential. Get in as soon as upon diagnosis for voice and speech treatment. It's essential to learn what to do to keep your voice and speech strong. Practice, get that voice and speech strong, and then you have the tools to continue to use to keep the voice and speech strong. Don't wait until it becomes a problem. At that point, it's harder for you to get that voice back up to normal loudness. When people come to see me early on, it's easier to get that voice to the normal loudness level and maintain it there. Telehealth sessions could be helpful if you notice you have a lot of fatigue and traveling and getting to a speech therapist, and we can give you more information about that through LSVT Global. And as a therapist, it's just important that we acknowledge, yes, this is hard work. You are working hard. You will feel tired during these treatment sessions, but look what you can gain with that normal loudness communication that can be heard and understood. So take-home messages here: behavioral treatments can be effective, and we're going to talk about how to get connected with therapists towards the end of this presentation. So I'm now going to turn this back over to Heather.
Great, thank you so much, Angela. Now, my portion as a physical therapist doing LSVT BIG, we will be talking about the exercises and the functional movements and how we can adapt that to the needs of people with atypical Parkinsonism. So let's take a look at the program. Next slide. So you may or may not be familiar with this depending on if you've had LSVT BIG before. But what we're showing you here is a snapshot of the program where we, on the left side of your screen, begin with what we call maximal daily exercises. And these are exercises aimed at improving your posture, and your strength and range of motion. On the right side of your screen, you're going to see more of what we call our functional tasks, where we're looking at something that you're going to do every day. And one thing that everyone must do is sit to stand. So we're going to work on functional movements that you do, and that may be simply being able to pull up your covers. That may be reaching for a drink. That may be being able to reach out for the remote. Depending on what it is that you feel you have difficulty with, we'll work with you on. And then we take it to the next higher level of functional movements, and we call those hierarchy tasks. And that is, again, things that you may be having difficulty with or don't want to lose the ability to do, and we'll identify those with you and work on them. So that may be the ability to get out of bed and be able to transfer to the bathroom or be able to transfer to a bedside commode. It may be able to get up from a wheelchair, get into the bathroom and use the toilet. It may be transferring in and out of the car. And again, it depends on what you think you're having the most difficulty with or your loved one is being challenged with, and we will build that up over the 4 weeks of treatment and make that much more challenging until it is something that you can successfully do. And much like LSVT LOUD, our sessions are 4 times a week for 4 weeks, and they are hour sessions. So again, you're getting a good workout, you're feeling challenged, you're working to a high level, and we're really helping you to get as much function back as you can. Our last functional area is big walking, and that may, for some people, maybe you're not able at this point now, by the time you see us, to actually safely walk on your own, and you're using a rollator, you're using a cane, perhaps you even use a wheelchair to get around. Well, we will still work with you to make that safer in a bigger way because the movements are small to begin with. So we need to push them to be bigger so that they're more normalized and more safe for you. Next slide. So the common adaptations that your therapist may use for these treatment sessions is it may be that your balance has progressed to a point where you're no longer safe to perform these things without holding on. We can absolutely adapt that. Your therapist can have you hold on to the side of a counter, hold on to a nice sturdy chair, a nice rail on the wall, something like that. You can also perform all of the exercises. They can actually be adapted to be performed in a sitting position as well as in a bed position. We are going to be releasing soon in the future videos of how we can adapt these for different people's needs. And right now your therapist, your LSVT BIG certified therapist, has the ability to have these handouts on the ready for you so that if you're performing them in sitting, in the clinic you'll have pictures of them to perform at home. Like Angela reported before, we really work quickly and very diligently with your care partner, so training the whole care team early on. And we want to be careful about your safety, so we have to look at some of the things we're doing and making sure that we're not causing you to have more of that orthostatic hypotension where you feel as though you're going to pass out. So different things that are going to work for you may differ for someone else, but these are some of the common adaptations that you'll see. Next slide. So what are these symptoms? What am I talking about? What will your therapist work on with you? Let's take a look at the next slide and we'll talk a little bit about that. So with PSP, remember that we talked about falls and balance being a big problem early on, as well as the difficulty with the eyes. So of course we're going to adapt our program to make you as safe as possible because we really want to prevent falls and we want you to be as safe with your walking for as long as possible. Now there's something that is coined in the literature as the rocket sign, and remember earlier I talked about how the frontal lobe of the brain is affected in PSP, and that can lead to people not making safe choices all the time with their movements. So when we talk about the rocket sign, this is when the person with PSP will move very quickly from sitting to standing without thinking about the safe way to do it, and then they actually end up falling back into the chair or on the floor. The rocket sign can be where people just quickly turn too fast to get where they're going. So we're going to teach you, and we're going to teach your care partner and your care team how to help make that sit to stand safer. Now when we're talking about the gaze difficulties, so the difficulty with looking up and looking down, we can do exercises with the eyes just as well as we can with the arms and legs. Blepharospasms are the opposite of where the eyes are kept open and you're not blinking. This is where the eyes actually close very tightly and you're not able to see what you're doing. So we will make adaptations and we will show you how to physically open your own eyes by using bigger movements with your hands. And then as well, Angela already spoke to the speech and swallow changes. Next slide. With the multi-system atrophy, those three variants that I talked about, we're attacking them all on those levels. So that MSA Parkinsonian, we're attacking those slow, stiff movements by making them bigger. And when we make movements bigger, we make them larger and therefore safer. We're going to work very diligently to, again, make sure that you're not feeling as though you're passing out or that you're feeling very dizzy. And then with the MSAC, the cerebellar, we're working really hard with your balance and coordination. So again, helping you to stay as functionally safe for as long as possible. Next slide. With CBD, again, we talked earlier about the apraxia, and that was what we talked about, that difficulty with using normal everyday objects and not being able to figure out what they're for, how to coordinate your movements. So if your difficulty is being able to reach out and pick up your coffee cup, or your difficulty is in moving your mouse, or in pulling up your pants, or being able to comb your hair, whatever that difficulty is, we're going to use some functional movements to do that. And as well as your gait and your balance and your mobility, but we want you to help feel better physically. So the odd movements or the feelings that people with CBD often talk about, that kind of shakiness, the clumsiness, that alien limb syndrome, sometimes we find that by making these really big movements and loosening up some of the muscles and improving the blood flow to that area, you can actually receive some comfort in those limbs. Next slide. Now the general points that you want to remember when you're working with your therapist for the LSVT BIG is that, Unfortunately, like we said, this disease process moves more rapidly than idiopathic Parkinson's, and that reason alone is why it's really important that early on in the diagnosis you begin your therapy. And that you may look not like the person who's sitting next to you in the clinic with the same diagnosis, because the symptoms and the way you present can vary a lot. So again, not judging ourselves based on others. Now, when we're talking about someone with idiopathic Parkinson's, our goal is to really restore and improve function, but with people with atypical Parkinsonism, sometimes we have to use some techniques where we're using compensatory techniques, where we're not looking at restorative processes, but kind of adding in some actual adaptations and compensation movements to still improve that mobility and to keep that person safe and to keep that quality of life high. Next slide. So the general treatment recommendations, like I said before, is you need to start your therapy as early in the diagnosis as possible, and you need to keep up with regular follow-ups with your therapist. So that means that once you're discharged from therapy, when you leave therapy, you should already be leaving knowing, hey, I'm going to come back. I have a follow-up appointment in 3 months, in 6 months, because I know that I'm going to lose ground. I know I'm probably not going to work as hard as I do with my therapist, and I know this disease changes, so I need to stay in touch with my therapist. Now, when you're in the later stages of the disease process, maybe you really didn't get a good diagnosis, maybe you didn't know about LSVT BIG until later on, it may be that your therapist may not recommend BIG initially, but however, next slide, you can always try that week of stimulability testing. As Angela was talking about before, we try that week with you to see if we can stimulate you to the point of being able to make those movements bigger and therefore faster and safer. So together you and your therapist will figure out if LSVT BIG is the right treatment session for you. You have to remember, beyond anything, the importance of preventing falls, and that means that you're talking and establishing that care team very early on so that everyone understands, you know what, Bob is having a difficult time because he has with this part of his brain. It causes him sometimes to not really make safe choices, so we need to make sure that we're there for Bob to remind him how he's supposed to get up from the chair, because he might not always remember on his own. He's not doing this on purpose. It's that he physically can't remember and make that choice to always do it safely. So important educational points early on after the diagnosis. Next slide. So we're going to show you some of the examples of what we do in treatments when we're talking about functional component tasks. Remember I mentioned the sit to stand. We work on really helping people to understand how the bigger movements, the bigger push to the front of the chair and the larger kind of forward motion really helps with preventing backward falling. Like I said before, you can also do eye exercises and eyelid exercises, so standing in the middle of the room and then having your loved one, they will hide tennis balls or different objects of certain colors and shapes in the room, and you're standing there, and without moving your head, you're looking around the room to find these objects. Naming objects, letters, words, numbers, and putting them on little Post-it notes around the room. So actually making those eyes do the movements that they need to do. The other thing that's really important with anybody with the atypicals, but particularly for people with PSP because of the tendency to fall backwards, is really getting into what we call this big stance, this big powerful stance. And you can see in the picture here, this person is not only separating the feet big, but she's also staggering them. So she has front to back support and side to side support. So getting into that big posture and big stance before you do any kind of activity to really help prevent that fall. Next slide. This slide is going to show you just some of the kind of, this is how we shouldn't do it and this is how we should do it. The people on the top are standing in front of the area of the thing that they need to move, so standing in front of the oven, in front of the door, in front of the cabinet. Look how close their feet are together. If they are to pull that door open, then that's going to fall back towards them and cause them to lose their balance backwards. So with the LSVT BIG therapy, we teach you how to get into that big stance and how to change the way you line your body up so that you can still do these tasks in a safe way. Next slide. So again, looking at other ways that people may be having difficulty with their function is the ability to return to sit, not just going from sit to stand, but oftentimes we will find that people will reach for the chair like this woman in the pink is doing, and then the movements get too small. So we practice things about making big turns in front of the chair, about maybe taking sideways steps so that you can avoid stepping backwards and not losing your balance. And then again, making a turn without pivoting. So we would literally practice with you, as in this picture here, of standing forward. If I want to turn to the right, I step with the right foot, and then I bring it back. I'm going to turn to my right again, big step to the right, or vice versa with the left. So we break these components down, and we do them repetitively with you. Next slide. So examples then for your therapist to use when you might have MSA or CBD, when we're talking about those functional component tasks, is if you're having difficulty with the high tone in your arm. So that functional component task could be about stretching that arm out to reach for something. If it's apraxia, then it's actually practicing that reaching of the key, that turning of the key, whatever that actual movement is. So whatever the functional problem is you're having, we're going to train to that problem. Now, when we're looking at someone with MSA, again, same thing, whatever that functional problem is, we train to it. We also want to help with whatever the particulars are that are keeping you from being able to do it. Is it because your movements are so uncoordinated? Is it because your balance is so poor? Can we help to get you in a better position when you do that? And then we also might have to do those functional tasks at a slower pace in a more deliberate manner, because we really need to make sure that we don't have that orthostatic hypotension or that feeling of a drop in the pressure and feeling dizzy. Next slide. So examples of what we talked about before with the hierarchies, those big multifunctional movements that you do, perhaps getting out of bed and getting to the bathroom. It's always good to remember that if individuals are in the later stages of the disease, it may be that it's not safe for you to get up by yourself. It's not safe for you to expect your loved one who has these diseases to get up without guidance. So sometimes just knowing that you need to ask for help and then having someone there to guide you in a big way will make all the difference. When we're working on your walking or your gait, again, we're going to use that assisted device. If you need that rollator, that's okay. I wear glasses because I have difficulty seeing. I would use a rollator or a device to help me with my walking if I had difficulty with walking. We mentioned before about PSP, where people's eyes don't move the way they want them to. So we do something called setting the eyes, meaning that someone will stop when they're walking, they will turn their eyes in the direction of where they're going, then they will turn their body. Because otherwise, sometimes the person with PSP is turning the body, but the eyes are looking in a different direction, and that can lead to falls. And again, with the MSA, we talked about dealing with the orthostatic hypotension before. Next slide. So I'm going to turn this over now to Angela, and she's going to talk to you about if you have and you are living with an atypical Parkinsonism, how would you get started with both LSVT LOUD and BIG?
Thank you, Heather, for those excellent suggestions. That was great. So if you're interested in participating in LSVT LOUD and LSVT BIG, and we can send this handout to you after so you have all this information as well. But step one is to ask your doctor for a referral and a prescription for speech, which would be the LSVT LOUD, or physical occupational therapy, LSVT BIG. And that prescription should be for the evaluation and treatment. You can also then go to our website, the LSVT Global website, and there's a tab that says find a clinician near you, and you click on that and you put in your zip code and whether you want LSVT LOUD or LSVT BIG, and then clinicians near you pop up and you can find those clinicians available close to you. We also do have some DVDs available that are meant to be an adjunct to the LSVT LOUD and LSVT BIG therapies. They're not meant to replace it, but it can give you an introduction to it if you want to take a look at those. And then when you start the therapies, you can use that as an adjunct as well and as a helpful tool for practicing after. So in conclusion, remember, there is hope there is something you can do to improve movement, to improve voice and speech. And as Heather introduced initially, therapy is essential for these atypical Parkinsonisms. We highly, highly recommend that you start therapy sooner rather than later for those reasons that we have previously discussed. And having those regular follow-ups with your therapist is essential. Use that care team, get them established early on, and they can be a support there for you. Here are some additional resources, and once again, we'll email you this handout, so you'll have these as well, but some additional resources for individuals who may have atypical Parkinsonisms. And now what we would like to do is open this up for questions, and so I am just going to take a look here and see what questions we might have. And first of all, we had a hand raised, and so I'm going to, Doherty, I'm going to unmute your microphone, and you are now unmuted if you would like to ask your question. And I don't hear that coming through, so if you want to try to type in your question as well, we can handle it that way. And let me just see here what other questions we might have that might have come through. And if you think of questions after this webinar, as I mentioned before, you can always email those to us at info@lsvtglobal.com, and we're happy to answer those as well. I don't see additional questions at the moment, so if you think of something after the webinar, please do feel free to send those to us, and we'll be happy to address those for you. Heather and I sincerely thank you for taking time out of your busy schedules today. We hope you have found this information helpful, and we're always happy to be here to be a resource for you. But we hope you have a fantastic day or a fantastic evening, depending on where you may be joining us from. And we look forward to visiting with you on future webinars. Thank you so much.